Thanks everyone for still being here. We've saved the best till last, which is another real-life clinician. Jayesh has come straight from Pod 2, whereby he's got some pretty sick patients, but he sees the greater good of talking to us today. He's talking to us as one of the PhD students that we've got in our centre about his approach to studying the disposition of inhaled antibiotics.
Thank you, Jason, for the kind introduction. So my PhD is on a study of the disposition of aerosolized tobramycin in particular. Now, we do know that pneumonia happens to be one of the most common infections in intensive care, and there's a fairly high incidence of nosocomial pneumonia in intensive care. And despite antibiotic therapy, there is failure of therapy, including mortality associated with ventilator-associated pneumonias. One of the major reasons, there are multiple reasons for the failure of therapy, but one of the reasons is inadequate antibiotic levels at the site of action, in particular in the lung tissue. Gram-negative organisms are predominantly attributed as one of the commonest causes for ICU-acquired pneumonias. And when there are inadequate antibiotic levels at the tissue level, there is also a risk of developing multi-drug resistant infections as well. So what are the different solutions we have for this type of problems? We can give them higher antibiotic dose, but that comes with a risk of developing systemic side effects. We can then wait for the newer antibiotics to develop. Again, the pipeline appears to be fairly dry, and even though there are some newer antibiotics coming through, they yet to be tested adequately in these scenarios. And so we need to now start looking outside the box. We need to start looking at novel delivery techniques, in particular targeted pulmonary drug delivery techniques. The different methods available for the pulmonary delivery of antibiotics are, in particular, intratracheal instillation, which are found to be cumbersome. For people who've worked in intensive care, you realize the whole exercise of disconnecting the patient from the ventilator is not a palatable technique to deliver antibiotics. The other option is to give them antibiotics via the aerosolized route. Again, in the current environment, while there is development in different formulations for aerosolized antibiotics, it's still limited in nature. The delivery of dry powder is seen to be the next thing in pulmonary delivery of antibiotic, but because you can actually deliver a higher amount of drug, but again limited by the available devices for ventilator-associated pneumonias. The pharmacokinetic principles comparatively between a conventional route to your inhaled route are a little bit different, where deposition of the antibiotic is a prime feature or primary pharmacokinetic feature that is important to achieve to have some sort of effective antibiotic effect. A number of factors affect the drug deposition when you deliver antibiotics via the inhaled route. Namely drug effects, drug factors, device factors, ventilator factors, circuit factors, and patient factors. For effective delivery of the antibiotic, one of the important features would be the particle size. And as you notice, actually, in the micron region, actually, you get this 2 to 5 micron size particles achieving the maximum pulmonary delivery. On the nano end, actually, there is a higher amount of lung delivery, but again, the problem at this point in time is that the delivery devices are hardly meeting the micron delivery, but there's no device at this point in time available to have the nanoparticle delivery. So we're going to focus our study on the micron particle delivery. And so devices are of multiple types, and over a period of time, there's been first, second, and third generation devices that have been developed to deliver the inhaled antibiotics, and of which the vibrating mesh nebulizer seems to be the third generation nebulizer, which seems to be very effective without causing any degradation in the antibiotic. So our hypothesis here is while it is all well and good to deliver the antibiotic, we do want to measure the antibiotic in the lungs and there are limitations in the current methods of measurement of antibiotics in the lung. So we're going to use that technique called as microdialysis in the lung to measure the antibiotics in the lung itself directly. And the antibiotic of choice that we've decided to use is tobramycin, and that's largely because it's a fairly commonly used antibiotic and it's well studied in cystic fibrosis patients, and a formulation is available and so on and so forth, and it's deemed to be safe and effective as well. The study is going to be, the project in total involves 4 discrete studies, 2 in vitro studies, which is the in vitro microdialysis recovery study, the particle sizing and inhaled mass study, and then we have the lung distribution and